Hello and welcome to the virtual version of Latin American Heart Rhythm Society. It's a pleasure to be here today, and it's a pleasure to be able to give this talk. And I'm going to talk about arrhythmias and Ebstein anomaly. How do we approach them in 2020? So, arrhythmias are commonly seen in Ebstein's, and we'll go over what those are. We'll talk about arrhythmias following the cone repair, intraoperative management, and then postoperative management. But you have to be careful because these arrhythmias can sneak up on you very easily. So if you look at the main arrhythmias in Ebstein's, it's a Wolff-Parkinson-White in addition to any type of atrial tachycardia with a dilation that you see in the atrium of these patients, intraatrial reentrant tachycardia or the so-called scar flutter, atrial tachycardia, and atrial fibrillation all may be seen both in the short term and long term in these patients. Epstein's anomaly has a relatively high incidence of arrhythmias. The arrhythmia prevalence in childhood is around 17%, with the most common of these being supraventricular tachycardia. The arrhythmia burden goes up further, and in adult congenital heart disease, 39% of hospital admissions are for arrhythmias. The most common of these are atrial fibrillation, but you can see other atrial arrhythmias as well as ventricular tachycardias in these patients. So in Epstein anomaly, we do what's called the cone repair, and this surgery is often done in adulthood, and this creates a problem with long-standing dilation or dysfunction. Arrhythmia pre and postoperative, we see Wolff-Parkinson-White in about 10 to 20%, SVT in 10 to 55%, and atrial fibrillation or flutter in 25 to 60%. One of the things that we're beginning to realize is VT is a real problem, and we see this in around 2 to 12% of patients with Ebstein's anomaly. With the ventricular dysfunction that we see as a native function of this disease, we do see ventricular dysfunction develop later. We can see increased early and late mortality, and death is often sudden in patients who have ventricular failure. This applies to both left ventricular failure as well as right ventricular failure. Now, in the cone repair, what we do is we basically take the tricuspid valve and we resuspend this in a cone-like structure. And what this does is we debulk the atrium and debulk part of this ventricle that is abnormal and is basically not functioning properly. What we know is this debulking and this procedure can greatly decrease the incidence of arrhythmias. In the study that we did at the Mayo Clinic, pre-cone, we see that they have this number of procedures, and post-cone, that's greatly decreased. In addition to that, we may also perform a surgical ablation. We know that IART requires a critical mass of atria to maintain the reentrant circuit. The larger the atria, the easier it is to maintain the circuit. However, a transmural lesion causing a complete line of conduction block can be created and must be created in order to divide the atrium into much smaller areas that can't maintain this arrhythmia circuit. The traditional cut and sew approach makes a definite transmural lesion because you cut all the way through the tissue. However, this is very time consuming and also creates a large amount of scar. The newer techniques use cryoablation energy using a very long probe that can be molded to the shape of the heart and then used to make very good lesions. As we notice that if we put right-sided lesions in, and there's a standard set of lesions that can be found in several articles, this will decrease the chances of flutter, but if there's atrial fibrillation, we need to add the additional left-sided lesions around the pulmonary veins and connecting this to the left superior vena cava and mitral valve when present. So if we look at prophylactic arrhythmia operations, should we do this in every patient that has Ebstein's anomaly? It is listed as an indication based on the surgical literature. However, there is concern about their potential proarrhythmic effect as ultimately electrical connections are reestablished across created lines of block. And we know that within 5 to 20 years, there will be these abnormal electrical connections that are created by the heart, even through complete lines of block. In addition, if we divide up the atrium into smaller areas, we may create a dysynchronous atrial contraction by making all these areas that don't contract very well. In patients with Ebstein's, they may actually need this atrial kick to fill their abnormal ventricle. So, by creating all these lines, we actually may make a situation where their atrium are not able to effectively pump blood into the ventricle, thus causing problems. If we look at the Mayo experience in patients who we do put these lesions in, the freedom from atrial flutter or fibrillation without any antiarrhythmic medications was 79%. There were no late strokes, and 84% were free from Coumadin. There was a trend towards higher freedom from atrial fibrillation without antiarrhythmic medications in a biatrial maze, i.e., the right atrial lesions as well as the left atrial lesions. So, in those patients who do have fibrillation or flutter, these lesions can be very effective at preventing recurrences. Now, if we look in the immediate postoperative period, we also see arrhythmias as an issue. The estimated incidence of postoperative arrhythmias is atrial in about 33 to 60%, or ventricular in less than 2%. So atrial arrhythmias occur in at least half of the patients postoperatively, but these arrhythmias can be very difficult to detect. Focal atrial tachycardias may be seen in the postoperative period, particularly in patients who have had an extensive surgery on the atrial tissue. There are these small areas of atrial foci that get irritated by the surgery and therefore may fire off very quickly following the surgical procedure. We know that if you operate on the atrium, especially a diseased atrium as an Ebstein anomaly, that you can get these irritable focuses. But a lot of times these will go away on their own. So if you see an atrial tachycardia within the first 24 hours, they have a pretty good chance of spontaneous resolution and are likely just from irritation. However, if they occur 2 to 3 days after the procedure, they're likely to be a long-term problem. So, for faster symptomatic tachycardias occurring more than 3 to 4 days after the surgery, they'll likely persist and therefore require some type of therapy. We know that patients with Ebstein anomaly have a higher risk of Wolff Parkinson White. They're also at a higher risk for sudden cardiac death because of their poor ventricular function and the fact that they may have multiple pathways. In addition, because of the diseased atrium, they're at a higher risk for atrial fibrillation. And in addition, supraventricular tachycardia may be poorly tolerated with dilated atria and poor right ventricular function. So it's very important to perform an aggressive evaluation on patients with Ebstein and Wolff Parkinson White. It can be tricky. It can be very difficult to see pre-excitation because these pathways don't act like the usual pathways. They tend to be very slowly conducting and can be very subtle. In this patient, if you just take a look at baseline, there's no obvious pre-excitation. But if you look very close here, you notice that the PR interval is normal and there's no right bundle branch block. In true Ebstein's anomaly, you should have a right bundle branch block and you should have prolonged PR interval. So when you don't see these things, you need to look very careful at other areas of the ECG. For example, this is the large P wave, and this is the pre-excitation that's seen there. So if you see in lead V1 no right bundle branch block and a normal PR interval, look very, very carefully because even without overt evidence of pre-excitation, the patient very well may have Wolff Parkinson White. In addition, because of the underlying bundle branch block, SVT and Ebstein's may be wide complex and therefore may get mistaken for a ventricular tachycardia. So in this particular case, we can see that there is a right bundle branch block. And you can actually see little P waves that are coming through here, but this is actually a supraventricular tachycardia with a slowly conducting accessory pathway. So the two pitfalls of this are, number one, recognizing that the underlying right bundle branch block is there and therefore not mistaking this for a ventricular tachycardia. And number two, seeing the presence of P waves, realizing that some of these accessory pathways conduct very slowly. Because this can get you fooled, because in these patients, you can clearly see here that there's a P wave, but you can clearly see that the P wave axis is abnormal. There's the underlying right bundle branch block again. But what you can tell is that because these accessory pathways are very slowly conducting, you may actually see a long RP tachycardia that's due to the accessory pathway. So this is one of the unusual ways that these accessory pathways present in Ebstein. And here's just a close-up of that. And you can clearly see it looks like there's a P wave or QR and a QRS. But this QRS is actually a reentrant circuit through the pathway going up, down the AV node, up the pathway to the atrium and back around. So this is a standard reentrant SVT, but because the accessory pathway conducts slowly, it presents different looking on the ECG. Now, we also have to be careful because these patients are at risk for atrial tachycardias as well as atrial flutter. Okay, it's a little bit easier to see here as you can see the distinct P waves marching through. The advantage of these patients is they usually have atrial enlargement, so the P waves are usually pretty large, and therefore it's easier to see when patients are having abnormal rhythms, particularly flutter. And if you look at this blow up, you can clearly see the P waves marching through the QRS, and you can clearly see that this is an underlying flutter. One of the things you have to realize that's a little bit different in dealing with these patients is adenosine has to be given a little bit differently than you typically give it. As you know, adenosine is rapidly metabolized by erythrocytes and endothelial tissue and has a very short half-life of around 1.5 seconds. And because it's directly metabolized by these red blood cells, as well as the tissue inside the blood vessels, if the adenosine sits around in the heart or vessels for very long, it will be quickly metabolized. Therefore, in these patients, because the flow is so sluggish in the atrium, you may need to give a very large dose, including up to 3 to 5 times the normal dose because of the poor atrial flow and the rapid metabolism. So realize, don't be afraid to give very high doses of adenosine because that may be what it takes to get patients out of their arrhythmias who have Ebstein anomaly. And realize that these atrial arrhythmias are not completely benign. And we know that the sudden death risk may be as high as 6 to 10% in association with recurrent atrial flutter. And recurrent atrial arrhythmias may have a significant effect on ventricular function. So we can't just say, well, it's just an atrial arrhythmia. I'm not that concerned about it. We need to be aggressive about treating this because of the risk of sudden death and also an effect on the ventricular function in these patients. We do also know that the AV node is in a little bit of an unusual position in patients with Ebstein. It's typically located within the triangle of Koch. It's a subendocardial structure and it's susceptible to injury during a tricuspid valve annuloplasty and the plication that's done for Ebstein. So it's important that when you talk to your surgeon about these repairs, they should be very aware of the AV node. If we look at the incidence of complete heart block following surgery for Ebstein's anomaly, it's 4.2%. And with the tricuspid valve replacement, it's almost 8%. So this is 2 of the top 6 surgeries for complete heart block in one study. So this surgery, the Ebstein's anomaly, with or without tricuspid valve replacement, has a high incidence of AV nodal damage that requires a pacemaker. And it also is more challenging to put a pacemaker in because you have to place the pacemaker lead past the repaired tricuspid valve. So it's very important to try to preserve AV nodal function in these patients if at all possible. So what do we do for follow-up as far as arrhythmias? And we'll take a look at the ACC AHA guidelines for the management of adults with congenital heart disease. We'll take a look at the 2018 update as well. So in patients with palliated defects, including Ebstein anomaly, the recommendation is regular Holter monitoring every 1 to 2 years. So because the arrhythmia burden is so high in these patients, a Holter monitor should be performed every 1 to 2 years. Exercise testing every 1 to 3 years, not only to follow ventricular function, but some of these arrhythmias may only be seen with exercise. And if a patient's had extensive atrial or ventricular surgery or scarring, they may require more frequent Holters as they may have a higher arrhythmia burden. If a patient has palpitations or syncope, very aggressive workup and evaluation should be performed as these patients are definitely at risk for sudden cardiac death. We do know that an EP study is reasonable before surgery even in patients without pre-excitation or documented SVT. Sometimes the surgery itself will decrease the arrhythmias following the procedure, but it's reasonable to look before, particularly in older patients. With Wolff Parkinson White, an EP study is also reasonable even without any other factors or symptoms, and even if a patient is not having surgery. So, our process at Mayo is if anyone has Wolff Parkinson White and Ebstein's, those patients get an electrophysiology study. If they've had palpitations or Wolff Parkinson's White before surgery, we will study them. But if they've had no palpitations and no obvious evidence of pre-excitation, we do not perform an electrophysiology study on all of those patients. So, in conclusion, arrhythmias are a common problem in Ebstein anomaly, and diagnosis and management can be very challenging, and we may need unique approaches for the treatment of arrhythmias. So, I'd like to thank the organizers for inviting me to give this talk, and I hopefully we'll be able to meet in person next year. But it's certainly an honor to be a part of the Latin American Heart Rhythm Society and the great organization and things that they're doing. So, thank you very much for your time.